everyone, please join with your student ID and with your name because this session has 10 marks for attendance. So if you don't attend by student ID, then we will be unable to identify you. So please attend with your student ID so that we can mark you. So can we start now?
Yes, yes. Is there anyone supposed to join? Okay, or we can
So they
start.
will they will join simultaneously. I have almost 20.
Okay, okay, good. So I'll share my screen. So you guys are 17 of you, right? So may I know a bit of background from you guys, just to
Sir,
keep things in context?
I'm introducing you. And sir, most of the students are MBBS students. Some are post MBBS and some are PGTs. But 95% students are MBBS.
Okay, okay, that's good because our
So,
my content is also very basic and more of conceptual from conceptual perspective. So it will be good if we can have an interactive session. Okay, so yes,
let me
should I share my screen?
uh, sir, let me first. I am introducing you, sir. Then you can start. Yes, so today we are welcoming Dr. Orkopal Bandyopadhyay, who is the Assistant Professor of Pharmacology at All India Institute of Medical Science, Kalyani. He has completed his MBBS, MD, DNB, and DM. He has completed DM in Clinical Pharmacology Pharmacology from All India Institute of Medical Science, Rishikesh. A dedicated clinical researcher, he specialized in clinical trial operations, antimicrobial stewardship, relation therapeutics, and medical device development. Over past 5 years, Dr. Bandyopadhyay had led many impactful research publishing in high-profile journals on the topic like vitamin D3 supplementation in CML and tenecliftin's effect in type 2 diabetes. Type 2 diabetes. His work is supported by prestigious grant from ICMR and other funding agencies in India. He is also involved in developing innovative diagnostic tools and personalized medicine strategies, recognized with the ICMR DMMCH Thesis Grant 2019 and the Research Day Award 2021 at AIMS Rishikesh. Dr. Bandyopadhyay is a frequent speaker at national and international conferences. We are welcoming Dr. Bandyopadhyay, sir, as a speaker for today's session. Sir, the floor is yours. Thank you.
Oh, thank you for such a detailed introduction, Dattatreya. It's good to be part of games for this academic event. I hope I am audible, right? Am
Yes,
I
yes,
audible
you
and
are audible.
my slides are
Yes,
visible?
yes, your slides are visible.
Yeah, so thanks for the introduction. So it's good to be a part of games for this academic initiative which you guys have started. And as I was looking at the topics, so you have covered very interesting topics like current situation of clinical trials in India, which is a very evolving topic, as well as various basic concepts of medical research, specifically pertaining to humans. So our topic will be very clinically oriented and very current, very clinically relevant in today's context, because we'll be discussing about randomized controlled trials. So as we already know that if you go through clinical research, I'm audible, right? Yeah. Everybody is there with me? Hello?
Yes, yes, you are audible,
Yes,
sir.
you are audible, but the rest of the people are in silent mode.
Yeah,
What about the
yeah,
others?
sir. Uh, they are actually muted. Abhishek, please open everyone's mic so that they can interact. Dr. Abhishek. I'm telling him to check.
Yeah, if anybody
Even
has any
Mike is
question,
there.
any queries, we can just stop and interact. Otherwise, it will be a didactic interaction. Yeah, so what I was talking about is the commonly used terminologies, right? So clinical trials, randomized control trials, double-blind trials, pragmatic trials. A lot of terminologies are being frequently used, and if you go through clinical research per se, you will be frequently encountering these terminologies, especially if you are one who has done your MBBS or MD during COVID times. You have seen a lot of clinical trials, being published in various journals, indexed and non-indexed. So, from level of evidence-wise, randomized control trials are at the peak, just below systematic review and meta-analysis. So, we'll be trying to decipher these points one by one. So, if you see from MCQ point of view, or many people must be preparing for PG, this evidence pyramid is very, very important, right? So, from basic background information from case series, case control studies, cohort studies, randomized control trial, followed by SRMA. I think you already had a session on SRMA, right? Anybody can confirm that?
Everyone can unmute their mic. Yes, sir. SRMA, there is a session taken by Dr. Indrajit sir, system review meta-analysis. One session
Yes,
was
because
taken.
I looked at one of the topics, it was there. So it's very important, very high yield topic. So randomized control trial is just next to that. So it has very high clinical significance. So just a question for all of you guys, if you can unmute and just answer this question, which research has maximum ethical concern? And not only the answer, because many of you will be dealing with MCQs, not only the answer, but explanation is also required. So which research has maximum ethical concern? Case control, case report, RCTs, or case cross-sectional studies? Anybody would like to answer? So it's a pin drop silence. Dattatraya, are everybody, are they present or they have just logged in and kept it in silence?
Isn't because they can unmute. I have changed the settings. Guys, please unmute yourself.
Okay, so it's a RCT, right? So randomized control trial, so which has maximum ethical concerns. And if you see just a overview or outline, there are patients, group of patients who are randomized, as the name suggests, to treatment arms and control groups, and they are subsequently given some intervention. After which you check out efficacy endpoints. By efficacy, you mean when you are in a controlled setting, you see changes. Suppose if I take example of diabetes, you check HbA1c, right? If I check diabetes for a group of new drugs, your primary endpoint will be HbA1c. Similarly, the secondary endpoints will be weight, fasting plasma glucose, lipid profile, that kind of things. Now, just a theoretical definition at experimental study designs. So there are subjects in population and are randomly allocated to one of the groups. Okay, and they are called study or control groups, and they receive or not receive. So basically, you have cases and you have intervention arms, you have control arms. So you have a probability of getting the treatment or not getting the treatment, right? So somebody has commented something in the chat box. We cannot unmute ourselves. Okay.
Sir,
So to
now they can
Mhm.
unmute.
Okay, okay. So to receive or not receive a treatment, right? So this is basically a very simple theoretical definition to make you understand. So basic the stages of conduct of a trial. If you see, plan a clinical trial, we'll go into details, but then you conduct, then you analyze the data, and then you interpret what the data is. So if you see many of your written protocols, you have submitted, projects for research. For various reasons, the general outline is very similar to that of a randomized control trial. So you have a background information, you have objectives, you have a study design, you have you have inclusion and exclusion criteria based on which you select participants for a disease particular. Suppose you want to select patients of rheumatoid arthritis. So what are the inclusion criteria and which patients you would like to exclude? And then what are the treatment, what are the interventions, then what are the efficacy assessment. Like in the previous slide, we saw that for diabetes, our efficacy parameter will be HbA1c, or a fasting plasma glucose, or a postprandial glucose by OGTT. And then lastly, to conclude, there is statistics, some kind of statistical analysis followed by documentation. You write a report and you present it. For clinical trials, it's very similar. So broad type, if you see what are clinical trials in India, there are investigator-initiated trials and regulatory clinical trials, right? So investigator-initiated, the term means the data which we get is not used for commercial purpose. When a company who is sponsoring a trial, or the doctor who is doing the trial does not have any commercial interest, so it is not for commercial use. Whereas regulatory trial, you need permission from the regulatory agency. Can anybody name what is the regulatory agency of India? What is the regulatory agency in India? Yeah, there are almost 22
Uh,
participants, if I'm not wrong.
CDSCO,
Right. What is the full form of that?
the Central Drug Standard Control Organization.
Yes, very good. May I know your name, please?
Saksham,
Saksham. Yes, and that CDCO is under which body?
Ministry of Health and Family Welfare.
Yeah, under Ministry of Health and Family Welfare, there is an organization known as DCGI, Drug Controller General of India. So under that, under the umbrella of DCGI, this CDSCO is working. So it is mostly dealing with regulatory trials, which the company uses the data of those trials for commercial purpose. Like you get approval for a new drug, you can do business with that based on that data, and you can get license from the regulator based on that data. Right. So this is what is very, very important. So whenever we are doing a randomized controlled trial, if you see there are three terms uh, in this heading, that randomized, controlled, and trial. Trial is explanatory, like you are doing some kind of research, but what is randomized? Can anybody tell me what is the meaning of this randomized and what is the meaning of controlled? Because based on that, we have certain assumptions, like you can see on the right side of the slide, there is assumption that whether we want to do a superiority trial, like treatment A is better than treatment B, or a non-inferiority trial, as the name suggests, treatment A is not inferior to treatment B. An equivalence trial where our assumption will be treatment A will be equal to treatment B. So they are more of understanding, and from statistical perspective, based on these assumptions, we calculate sample size of a clinical trial. So can you tell me what is the meaning of randomized? And what is the meaning of controlled? So randomized basically means you have equal probability to go in either arm of the clinical trial. So if it is a two-arm clinical trial, you have treatment A versus B. A patient who is being recruited in the study has equal probability of going into either of the arms. Okay? And controlled means when you test a new drug or a new standard drug or an old drug with a new indication, you compare that with a standard drug or a placebo. Okay, a new drug is being compared with either a placebo or a standard drug for an indication. So what do you mean? Now my question is, what do you mean by placebo?
There is no actual
Yes,
drug. They are just under
yes,
the psychological this that
yes,
this is a
very,
drug.
very good. Yes, so basically it is for medical perspective, it is a pharmacologically inactive substance, right? There is no pharmacologically active substance in that. So pharmacologically inactive substance that is used as a placebo to see whether the new drug actually has some effect or it is just by chance. You can also have active controls for a study where you already have a standard drug for that treatment. Suppose for diabetes, a patient, if I do a clinical trial on diabetes, patient diagnosed with diabetes, I will not give a placebo because I already have several established drugs. I can compare my new drug like I had shown in the first slide. There was a dual SGLT1 SGLT2 inhibitor. I was comparing it with SGLT2 inhibitor. So SGLT2 inhibitor, as you might know, is dapagliflozin, a very commonly used SGLT2 inhibitor, was used as an active control. So there can be pharmacologically inactive control like placebo, or there can be active control. Now, whenever you are seeing objectives of clinical trials, so they are normally conducted to, clinical trials are conducted to evaluate new forms of therapy. It can be drugs, it can be devices, it can be lifestyle interventions, it can be methods of prevention, it can be like vaccines, it can be various screening programs. Like you want to screen for breast cancer, you want to screen patients for genital cancers, all these things. Any kind of intervention can also be included in the clinical trial as objective. So if you see the case from the first slide which I had shown, we had compared the efficacy of the unknown drug X versus SGLT2 inhibitor, that is dapagliflozin, in reducing HbA1c in patients with uncontrolled type 2 diabetes at 24 weeks. And then the secondary objective, usually for any research, you always have a single primary objective unless it is a composite objective. You must have seen in research study design classes or how to write a protocol, where you studied how to write a protocol. There's a primary objective for a study and there are multiple secondary objectives. Like in this case, we have body weight, fasting plasma glucose, lipid profiles as our secondary objectives. So any change from baseline with respect to standard drug, that is dapagliflozin. Okay, so smart objective is a very, very important point. It has to be specific, measurable, achievable, relevant, and time bound. If you see the time, it was 24 weeks for that previous study. Okay, and whenever we want to do a clinical trial, for a commercial purpose, you have to get, like your friend Saksham said, you have to get CDSU approval. CDSU is under DCGI, that is Drug Controller General of India. It is directly under Ministry of Health and Family Welfare. And before we start the study, all clinical trials have to be registered in this website, that is Clinical Trial Registry of India, or CTRI, right? Can anybody who is doing MBBS outside India in this group? Or anybody who has done MBBS from outside India, can you tell the registry for US, for Japan, for China? Because all these countries have very country specific registries. Like in US, there is clinicaltrial.gov. WHO has a separate set of registry. Then China has different set of registries. All clinical trials who are undergone in China has to be registered in that registry. Now, whenever you are reporting a clinical trial, this is the basic flow which you have to maintain. So this is known as consort. It is basically a consortium of reporting randomized controlled trials. Okay, you have enrollment of patients. Patients who are checked for eligibility, they are subsequently randomized into treatment groups. So if you can see, they are allocated either to, is my pointer visible? So you are allocated either to interventions or either intervention A versus intervention B, and then you gradually follow up those patients over time, and at last you analyze the data. Okay, so this is a typical flowchart of a randomized controlled trial. Now, if you see what are the different types of study design, which itself is a class, a very basic RCT study design is parallel group, where you have two parallel groups. One group is getting the experimental treatment and one group is getting the control treatment or the standard treatment. Or if you do not have a standard treatment, you can give the patient placebo. Okay, so you screen patients for eligibility and then you subsequently randomize patients into either of the treatment arms and then you check for outcome. So you have a baseline assessment, then you have a baseline screening followed by baseline assessment and followed by the intervention of choice. And it is checked over a period of time. Very, very important. So now if you see another type of study design, which is I'm taking a class. I'll give you a call. So once a crossover RCT, if you see the study design, so you screen patients for eligibility and then you randomize the patient into either experimental or control group, and then over time you change the experimental and control group. By that I mean that the control group patients will be going to the experimental arm and the experimental group will be, this is wrongly written, okay? The control will go to the experimental arm and the experimental group will be going to the control arm. Okay, so basically there is a switch of the groups and this is done with a washout period. Can anybody tell me what can be the washout period? Washout period is the time by which we are assuming that all the drug will be successfully removed from the body. Can anybody tell me what is the approximate washout time for the drug or how we calculate it?
So 4 to 5 half-lives.
Yeah, 4 to 5 half-life is a good approximation, especially in common drugs which are not immunosuppressive in nature. So by 4 to 5 half-life, we assume that around 90 to 95% of the drug will be eliminated. So that is a good estimation. Okay, so we take washout. There are other factors also on which washout period is calculated, but generally half-life is the most commonly used parameter. Then there is another type of design known as a factorial design. By that, we mean that you have multiple intervention and you have combination of all the interventions. Suppose in a simple parallel design, you see there is test and control. Whereas for a factorial design, if you have two treatment arms, so you have combination of A plus B, then A, and a control arm. So basically it is a 2 by 2 table of all the interventions possible. So if you have three combinations, so it will be a 3 by 3. That is a 9-arm clinical trial. So now the three important concepts which we must know is randomization, blinding, and allocation concealment. So 3 terms. So as randomization we were discussing, has patient has equal probability to go into either of the arms. of the clinical trial. So simple randomization, you just simply toss a coin or you generate a random number table and you get a randomization schedule. The problem with simple is there can be unequal distribution of the patients. Suppose if you have 40 patients, there can be a chance that first 20 patients are going to one group and the next 20 patients are going to another group. So in case the patients develop any side effects after suppose 15th or 18th patient, then you do not have data for the other group of patients. So to avoid this kind of confusion, we usually have a block randomization. So patients are divided into blocks. So if you have 40 patients, if you take block of 4, so you basically have 10 blocks where in each block the patients are equally distributed like A and B, then A, B. So by A and B, I mean treatment A and treatment B. Okay, so each block is uniform. So suppose after 4 blocks, you have 16 patients. So you have equal number of A and B patients for analysis. So this is basically helpful for balanced participant distribution during the study. This is another example of a block randomization. Other way of randomization is basically stratified randomization, where you can stratify by age, by gender, by sex, by disease stage. So that also can be done. And another new type of randomization is the adaptive randomization, where you modify or adapt according to the clinical trial requirements. You must have seen during COVID-19 that this randomization is very common. Suppose you have 3 treatment arms, and after halfway into the trial, I find that one arm is not giving good results. So I just can stop that arm and I can continue the patients in the remaining 2 arms. So that is a advanced form of randomization where you can adapt based on the results and you carry forward the study. So then coming to blinding and blinding and allocation concealment. So it is basically used to minimize any kind of bias in measurement of outcome. So an open label clinical trial means nobody is blinded. That means that if I am the investigator, I am allotting treatment to my patient. So I know what treatment I am giving to what patient. Whereas on the other hand, if I am blinded, I do not know. I am just looking at a number and I am giving the treatment which is being dispensed by somebody else, then that is known as blinded. So if I am blinded and the patient is blinded, so both of us are blinded. So in that case, it is known as double blinded. And triple blinded is when the statistician who is analyzing that data is also blinded. Another very, very important step is allocation concealment, where we are unable to predict what the next patient will be getting. Like before blinding, so if I know the sequence of the number, if I don't know exact treatment, but I have a number like 1, 2, 1, 2, like I had shown in that A-B sequence, so I can predict that the next patient will get A or B treatment, and if I can guess what treatment that is, I may be biased to give the better treatment to a patient who has a less severe disease. To avoid these kind of confusions, or to reduce the influence of the investigator on assigning the therapy, allocation concealment is used, where you do not have the numbers directly and you put those numbers in a sequentially numbered opaque sealed envelope. That is known as the snooze concept, and this is very commonly used during clinical trials, especially academic clinical trials. And during in sponsored clinical trials, you have digitally numbered containers where the placebo or the active control is exactly similar to that of the other drugs. So, or a central randomization where a computer will generate the number, and based on that you have to allot that numbered vial or tablet to the patient, so there is no chance of bias. So bias, is very, very important. It's basically the overestimation or underestimation of a measurement in clinical trial. So there can be various stages on which bias can occur, that is during the protocol design, or during conduct of trial, during analysis, during interpretation, or during publication. All cases bias can occur. So the most common ones are selection bias. So you preferentially select a good patient for the intervention arm, or you have allocation bias. or you have assessment bias, or you have publication bias. I will prefer to publish the article in the journal where my friend is a editor in chief. So he will get my article published, even if it is not relevant to the journal. That is known as publication bias. Or if I have negative results, I will not report that study. Or if I have only positive clinically significant results, I will pay some money and publish that data. So again, that comes under publication bias. So if you see, there is another term known as cluster randomized controlled trial. Well, individuals are not randomized as a whole, but I am randomizing a cluster of or a group of patients. Suppose I am doing a study on vaccine, effect of vaccine on childhood incidence of measles, and clustering children based on villages. So I have one village as an intervention and one village as a control in each district. I am not identifying or categorizing every children per se as individual patients, but I am clustering them into a whole village as one intervention group. So that is how the cluster intervention occurs. The intervention cluster, the control cluster intervention. Like so, again, a pragmatic clinical trial is a concept where you measure effectiveness. There is no concept of efficacy because it is mimicking a real life scenario where a patient comes to you in the OPD and that patient will be randomly assigned to either the treatment arm or the control arm. So there is no strict inclusion exclusion criteria, and they mimic the practice in real life. So this is known as a pragmatic clinical trial. Now, if you see the trial design for this is a very, very important topic where you should spend some time and try to understand whenever we are analyzing or you are conducting a clinical trial. So the trial treatment details has to be explicitly mentioned, like dose, duration, route, the study duration details, the description of the study, like stopping rules,
Are you a part of
discontinuation,
any
dose
research
adjustment.
trial, etc.?
I was a
Then
part. Now I don't want to be a part.
dose interruptions.
Enough of
Then
this.
yeah, I think Shannon can just
বলে এটা আসল বাচ্চাটি
mute
10
yourself.
এমপি বিয়ের রাখুন স্যার স্যাম্পল
Yeah, so stopping rules, discontinuation criteria are very, very important during the course of the study, because if a patient develops an adverse event, then it is very, very important to have strict criteria based on which we'll just stop the study, or you will exclude the patient from the study and give him or her the appropriate treatments. That is very, very important. Now, assessing outcomes is equally important. So efficacy, if you have seen in the pragmatic clinical trial, we have mentioned effectiveness. Can anybody tell me what is the difference between efficacy and effectiveness? Anybody can tell me what is the difference between effectiveness and efficacy?
It is the difference between how well the drug works in a controlled condition compared to the real-time condition, real world.
Yes, very good. May I know your name, please?
Saksham.
Saksham, yeah, right. You are absolutely right. So in controlled situation with very strict interior suppose inclusion exclusion criteria, you assess what is known as efficacy. But in real life situation or in a pragmatic situation without strict inclusion exclusion, you evaluate effectiveness of a drug. Okay, so when you're considering safety, you have studied in detail in pharmacology, I'm assuming, how to report adverse events. Adverse event and adverse drug reaction. How do you differentiate that? I hope everybody is clear about an adverse event which may or may not be related to the adverse drug reaction. When it is, and how do you do it? You do a causality assessment. You do what is known as a causality assessment by WHO UMC scale or a Naranjo scale. There are strict criteria or questionnaires which has to be, which you have to check before you can label an adverse event as an adverse drug reaction. That is very, very important, and there are several grades by which you can categorize severity of adverse drug reaction. So if you see the grading, that is what I was discussing. So if you can see urinary tract infection. So I was discussing about dapagliflozin. Can anybody tell me how urinary tract infection is related to that drug? How urinary tract infection is related to dapagliflozin?
Sir, due to
So,
increase in glucose, there is increased bacterial growth or chance of UTI.
Yes, so increased glucose is excreted in the urine. Glucose and sodium, due to inhibition of those SGLT2 SGLT2 receptors, glucose and sodium is excreted in the urine. So there is increased glucose, as you were saying, that it is leading to increased UTI. So UTI is very common side effect. So if you see grading of UTI, grade 2 is basically local when you treat with antibiotics. Grade 3 you have to give IV antibiotics. Grade 4 is a severe form of reaction where it can have life-threatening consequences. And grade 5 obviously is death. So whenever we are analyzing data, so there are two assumptions. One is per protocol analysis and another is the intention to treat analysis. So intention to treat basically includes all the participants who have been randomized. Suppose I have 100 patients who were randomized at the beginning of the study. I will analyze all those patients at the end of the study in spite of them, whether or not they are continuing the study. Okay, a patient can stop in between and leave the study after, suppose 4 months, 6 months. Some patients may miss the scheduled visits. Some patient may not take the medication. Some patient may withdraw consent from the study. In spite of that, if I take all the patients into analysis, it is known as ITT. Whereas per protocol is the type of analysis where exact protocol is being followed for the patient during the entire course of the study. Suppose out of 100 patients in the study, all 100 were included in ITT, but out of 100, only 50 patients had exactly followed the protocol till the end of the study. So the per protocol population of analysis will be 50 for this patient, for this clinical trial. So again, another term is important, which is non-randomized clinical trials or non-randomized trials, also known as quasi-experimental studies, where you basically do not randomize and you just give option to the patient that whether you want this treatment or that treatment A or treatment. So it is non-randomized study. Now, very important from MCQ perspective are this how to report studies. If you see for reporting clinical trials, consort is the guideline, whereas for other studies, there are various guidelines which are present in public domain. The Equator guidelines, or if you go to a website known as Equator Consortium, you will get all these guidelines. Like for systematic review, you must have heard of PRISMA. For diagnostics, there is a START criteria. For case report, there is CARE criteria. Okay, so these criteria, I think you should go and just go through it if you are planning any research on these domains. So that's all from my end, very brief. If you have any question, we can have a discussion for the next 5-10 minutes. Thank you. So any questions from your end?
Sir, sir, am I audible?
Yes, Kenil, please go ahead.
Sir, I wanted to ask that if I want to do meta-analysis or a review on that, so what should be my first step to get familiarized with to begin with? what should I do?
If you want to do a meta-analysis,
Yes, sir.
so you have
should
to understand the steps of meta-analysis first, like how to do a systematic literature search. That will be your first step. Then first of all, you should have a topic in your mind. So what are the topics or probable topics on which you want to do? Then you have to do a systematic search, and then you have to go to meta. So meta-analysis is the last part of the multiple steps of systematic review. Okay, so first you have
okay.
to do systematic review, especially if you want to do systematic review of randomized control trials. So you have to look through a website known as Prospero. Have you heard of that website, Prospero? So
No, sir. I'll search it.
because before you plan a meta-analysis or systematic review, you have to register your protocol in Prospero. So you have to see first whether anybody else has registered or not. If not, you can register your study, and then you plan a systematic literature search. Then you do the search, and subsequently you can do a meta-analysis if you have enough data from that systematic review. Am I clear?
Yes, sir. Thank you, sir.
Welcome.
Is there any questions from? Is there any questions from others? Thank you, sir, for the wonderful lecture, sir. I think the questions are not.
No
If there are
issues.
any
If you have any
questions,
question, you
send
can let
us.
me know.
If they
Sure,
send us the questions, I will mail.
sure. Okay, thank you all. Thank you for your participation.
Thank you,
Okay, can
sir.
I log out? Okay, thank you.